for joining me today to discuss hepatitis B reactivation with the specific focus on immunosuppressive medications. After this 15 plus minute talk, I hope you'll feel comfortable defining what hepatitis B reactivation is and identifying those immunosuppressive therapies that can increase the risk of hepatitis B reactivation. I hope you'll be able to describe some of the manifestations of hepatitis B reactivation, as well as identify the preventative tools we have available. And then finally, be able to risk stratify your patients to identify their particular risk of hepatitis B reactivation. So I'd like to start with a clinical case just to frame the discussion. This is a 59-year-old female I saw a few years ago who has debilitating rheumatoid arthritis. And when she came in, she was really managed with prednisone for 10 milligrams a day and was planned to transition to etanercept, which is a TNF or turmeric necrosis factor alpha inhibitor. And knowing those agents are associated with reactivations of various infections, she was screened, and her screening labs were notable for a detectable hepatitis B surface antigen, a hepatitis B core antibody with no hepatitis B viremia detected. The remainder of her medical history included some chronic kidney disease, osteopenia, and a C-section for which she received a blood transfusion in the early 70s. Again, her medications, prednisone, as I mentioned, lisinopril, and calcium and vitamin D supplements. Her family history was pretty strong for rheumatoid arthritis, but no known history of liver disease. She's US born and had absolutely no international travel. She is currently disabled, really worked in offices previously, and cares for her vaccinated grandchildren. She's a former smoker and has no alcohol or illicit drug use history. And her labs here, notable labs highlighted, noting again that chronic kidney disease, but no evidence of hepatic inflammation or synthetic dysfunction. She has Hep A immune, Hep C negative, and her tuberculosis interferon gamma release assay was also negative. Her imaging was noted for really no nodularity that would be suggestive of advanced hepatic fibrosis or cirrhosis, no mass, and a transient elastography was consistent with about F0 to F1 fibrosis, really minimal to no fibrosis. Her exam, really no stigmata of any decompensated liver disease. And so the questions arise, what is this patient's specific risk for hepatitis B reactivation? And based on that risk, what, if any, therapies does this patient need with regards to hepatitis B active agents? So let's first define hepatitis B reactivation. This is an abrupt increase or reappearance of hepatitis B DNA, but can also be defined as a reverse seroconversion, or sometimes called seroreversion, in which a patient who has no detectable surface antigen subsequently becomes positive for that surface antigen following initiation of immunosuppressive therapies. There are a number of laboratory definitions that have been used in the literature. Two I'll highlight here that are endorsed by the American Association for the Study of Liver Diseases, basically differ based on your baseline hepatitis B profile. So among those with detectable surface antigen at baseline and no or low levels of hepatitis B DNA, reactivation will be defined by at least a 2-log increase in hepatitis B DNA or an absolute DNA level greater than 1,000. Among those patients with no detectable surface antigen at baseline, but a positive core antibody with no detectable DNA, that seroreversion, or that new presence of hepatitis B surface antigen, or the appearance of hepatitis B DNA, would be a definition of hepatitis B reactivation. And so why does this even occur? Why does hepatitis B reactivation occur? And we know that in the nearly estimated 2 billion people worldwide who have been exposed to hepatitis B, this covalently closed circular DNA will persist in the hepatocytes. And you can see in the schematic here, the hepatocyte with that CCC DNA, which serves as a mini chromosome to allow for viral transcription to occur and really serves as reservoir for hepatitis B reactivation. Yet we know the immune system really can control, for the most part, hepatitis B replication with both humoral, the B and T cells, and innate, including cytokine, TNF agents, things along those lines. But we do know that the impairments in these arms of the immune system can result in reactivation, and we can identify some of these immunosuppressive medications by where they act on that immune system to identify those agents at increased risk for reactivation. So what's nice about this schematic is you can see some of those themes of those classes of immunosuppressive medications, where they act and why they increase that risk of hepatitis B reactivation here. So how do we identify patients at risk for hepatitis B reactivation in the setting of those immunosuppressive medications? Well, fortunately, there are a number of societies that recommend screening for hepatitis B prior to the initiation of any immunosuppressive therapies. What you'll note here is a number of them I recommend both surface antigen and core antibody, but some also recommend this hepatitis B surface antibody. And that's really interesting, but it's important to note that while some studies have shown that higher titers of hepatitis B surface antibody may reduce the risk of reactivation, the presence of hepatitis B surface antibody is insufficient for the prevention of reactivation of hepatitis B in the setting of a core antibody positive patient. And so how well do we do with these screening? Well, unfortunately, there are still quite low rates of hepatitis B screening among patients prior to the initiation of immunosuppressive therapies. And these rates may vary based on specialty or immunosuppressive agent use. But one compelling example is from the Veterans Affairs Administration, where you could see in this group of patients, they were undergoing treatment with B cell depleting therapy, so very high risk for hepatitis B reactivation. And during this time frame, you see very low rates of hepatitis B surface antigen being screened at all prior to initiation of those therapies. And you may say, this is 2004 to 2014. It may be a while ago, but what's important to note is the CDC actually recommended universal screening for hepatitis B among those planned for immunosuppressive therapies in 2008. So despite those recommendations, you still see low therapies. And in fact, at the end of the study period, less than or 53% or less of patients were actually screened for hepatitis B surface antigen prior to initiation of that anti-CD20 agent or those B cell depleting therapies. So what is the magnitude of risk of hepatitis B reactivation with these therapies? And they largely vary depending on which agent's being used, some of the hepatitis B viral profiles, and host factors as well. And I think to sum up those highlights or those major risk factors, is that there's significant increased risk with those B cell depleting therapies, that is those anti-CD20 agents or rituximab as one type of agent, the presence of surface antigen or elevated hep B DNA, and among those with hematologic malignancies. You can see here, there's been a number of meta-analyses published to try and get at the exact magnitude of risk for each of these immunosuppressive therapy classes. And while you can see that there's a widely variable estimates, what I hope you glean from this table is that really the risk is highest among those with surface antigen detection prior to initiation of those therapies, and while lower is still present among patients with detectable core antibody without that surface antigen positivity. And so we talked about hepatitis B reactivation as laboratory findings, but what are the actual clinical manifestations? And this can really range from a spectrum of asymptomatic laboratory findings to fulminant liver failure and death. And this is a schematic of what you can see with hepatitis B reactivation following the initiation of immunosuppressive therapy. First, what tends to occur is an increase in hepatitis B DNA, which is largely asymptomatic. However, this can be followed by an increase in liver aminotransferases that result in either a biochemical hepatitis profile, but can also progress in a proportion of people to hepatic dysfunction and a fulminant liver failure. And while some patients can have spontaneous recovery or improvement in those clinically significant outcomes with initiation of therapy, that may not be enough to recover those patients from those clinical outcomes. And so preventative therapies have really been used as a standard of care to prevent these highly morbid outcomes and decrease death. So what are some of our preventative strategies we have for hepatitis B reactivation? And really there's two approaches I'll highlight here. And one is prophylaxis, and that is specifically starting hepatitis B active therapy at the start or immediately preceding immediately preceding immunosuppressive therapy. And this has been shown to decrease the risk of hepatitis B reactivation, clinically significant hepatitis, and liver failure. And just again, some compelling examples. This shows shows a group of patients with core antibody positive, but no surface antigen detected at the start of chemotherapy with rituximab. That is a B-cell depleting therapy, again, high risk for reactivation. And what you can see here, in those who were started on entecavir prophylaxis at the start of that therapy, their risk of hepatitis B reactivation was significantly lower than among those who were not started on that therapy at the initiation of rituximab. And so you might say, well, this is entecavir. What about other agents, lamivudine, tenofovir, that are widely used as well? And again, there are a number of studies, but this is a nice randomized control trial looking at patients who have initiated rituximab-based chemotherapy for diffuse large B-cell lymphoma. And among these patients who were started on prophylactic therapy, we could see that in patients who were on entecavir versus lamivudine, the entecavir arm had decreased rates of not only hepatitis B reactivation, but also decreased rates of hepatitis B-related hepatitis, and had less needs to have chemotherapy interrupted during their treatment course here. And so, what we derive from this is that in this patient population that was followed up for a median of about 40 plus months, that lamivudine, knowing that resistance can occur within shortly after 6 to 9 months or so of therapy, that may be the reasons for this arm to fail more often than entecavir with a higher barrier to resistance. And so this really resulted in recommendations to use hepatitis B therapies with a higher barrier to resistance, particularly among patients who will receive immunosuppressive therapy beyond 6 months. So that's prophylaxis, but there are preemptive strategies among a subset of patients at risk for hepatitis B reactivation, in which a Hep B active agent would be started at the initial evidence of hepatitis B reactivation, that is, that increase in hepatitis B DNA following immunosuppressive therapy. And this strategy has also been shown to decrease the risk of hepatitis and liver failure. However, one of the challenges, or some of the challenges associated with the strategy, is that diagnosis of hepatitis B reactivation may be delayed if there's not regular interval follow-up, and it may actually necessitate interruption in some of their immunosuppressive therapies if it results in a fulminant liver failure picture as well. But either one of these strategies, it's important to note that hepatitis B active therapies are often continued for at least 6 months and following cessation of that immunosuppressive therapy. So knowing that, how to identify hepatitis B reactivation, how to identify those at risk for hepatitis B reactivation, and knowing some of those agents that increase the risk for hepatitis B reactivation, what are some of the tools we can use to help manage our patients in the clinic? And fortunately, the AGA in 2015 really provided a great clinical tool to allow clinicians to risk stratify their patients accordingly. And so I'll show a couple of these slides, but basically this group synthesized the available data to identify agents that would be classified as having a high risk of hepatitis B reactivation, that is greater than 10% incidence, and in contrast to those with moderate risk and low risk or less than 1% incidence of hepatitis B reactivation. You can see some examples here as well. But to jump right into this clinical decision support tool, you could see among patients with potentially high risk for hepatitis B reactivation, you could first stratify based on their hepatitis B profile. So among those with detectable surface antigen, you could see either use of those B-cell depleting agents, anthracycline derivatives, or moderate to high dose prednisone for more than 4 weeks. All of these patients should be treated with hepatitis B prophylaxis. The difference here is that among those with detectable core but no surface antigen, if they are going to be receiving those B-cell depleting agents, they should also receive hepatitis B prophylaxis. And again, the difference between these two groups is that among those with B-cell depleting agents, given the profound and prolonged impact on immunosuppression, the duration of therapy or prophylaxis is recommended for at least 12 months beyond, in contrast to this group of only needing at least 6 months of therapy. And so among those with moderate risk, a similar stratification approach should be used based on the presence of surface antigen positivity or negativity here. So among those with surface antigen positivity, those at moderate risk of hepatitis B reactivation would be those patients who are receiving therapies such as TNF-alpha inhibitors, cytokine or integrin inhibitors, tyrosine kinase inhibitors, or low-dose prednisone as well. And then among those without surface antigen, but detectable core antibody, really the same agents in the middle box here hold, as well as that moderate to high dose of prednisone for more than 4 weeks for the anthracycline derivatives. And among these patients, hepatitis B prophylaxis for more than 6 months after the last immunosuppressive therapy should be considered. Although there's a caveat that in some of these groups, some patients may prefer to forego a daily therapy and instead have close monitoring off of prophylaxis with plans for initiation of Hep B active agents if reactivation develops. And then finally, our low risk group of patients starting immunosuppressive therapies. And again, stratified based on that hepatitis B profile. Among those with detectable surface antigen, low risk immunosuppressive therapies would really be any oral corticosteroid for less than 1 week. Those traditional immunosuppressive agents such as methotrexate or intra-articular corticosteroids. Similarly, among those with core antibody positivity, low-dose prednisone, again, would really be low risk for any hepatitis B reactivation. Hence, no routine use of hepatitis B prophylaxis is indicated in this group. So to go back to our case for our 59-year-old female with rheumatoid arthritis on prednisone at 10 milligrams, planning for etanercept, a TNF-alpha inhibitor. She's surface antigen positive, core antibody positive with no hepatitis B DNA detected. And so her risk of hepatitis B reactivation due to the immunosuppressive therapy is high. And with the prolonged prednisone use at moderate dose and TNF-alpha inhibitor use, plan to give her prophylaxis with entecavir. I avoided tenofovir in this setting because of the renal sufficiency and osteopenia, and plan for indefinite prophylaxis given the anticipated need for etanercept for a prolonged period. So in sum, it's important to screen everybody for hepatitis B infection prior to initiation of immunosuppressive therapy, and to risk stratify based on the hepatitis B profile and immunosuppressive therapies to inform the treatment needs, and to continue that prophylaxis for at least 6 months following cessation of immunosuppressive therapy. So I'll stop there and take any questions.
Awesome. Thank you so much, Dr. Torgerson. That was really, really helpful. And I think a great way to kind of make something kind of complicated simple. So I appreciate your explanations very much. Just want to see if there are any questions specific to reactivation from the group. It sounds like I wonder from your experience, are you seeing anybody that is undergoing this specifically risk of reactivation? And it sounds like potentially the prophylaxis is probably your preferred method. Is that correct?
Yeah, I think, I always think about, a preventative intervention, even though if it's a low risk of very fulminant liver disease, I would rather prevent that outcome with a daily therapy that has minimal toxicity and high tolerability. So I tend to lean towards initiating prophylaxis, particularly in that moderate risk group. There are a number of people who just say, I can't do another pill, I can't do another medication, not good with medications. Unfortunately, those in my experience have also been patients who are not so good about following up with laboratory monitoring to identify reactivation. So it's a risk benefit ratio that really requires a patient engagement and to identify the best strategy forward. What's nice is that there's a recent publication available as an EPUB right now from the Journal of Hepatology that was the same group from AGA in their 2015 guidelines looking at updated data on reactivation among newer biologic therapies. And I think that is also helpful as we're seeing more patients with these newer agents to identify their risk and stratify accordingly. And so some of those data suggest a potentially lower risk for at least our core antibody positive patients. So employing those data to help inform our discussions with our patients is really helpful.
And for those that are not in the boat of wanting to take the prophylaxis antiviral, how often are you monitoring them with the blood work? And you're doing DNA, are you doing other things as well?
Yeah, that's a great question. And unfortunately, no data to identify exactly the right strategy. Depending on their risk. So in people with advanced hepatic fibrosis, cirrhosis, they're certainly be more worried about the clinical outcomes of hepatic synthetic dysfunction and decompensated liver disease. And so I'd probably monitor them a little bit more closely, particularly after the start of immunosuppressive therapy. So anywhere between 1 to 3 months of interval labs, including not only hepatitis B DNA, but ALT or liver aminotransferases to really identify any evidence of biochemical hepatitis and to potentially intervene early on. But otherwise, looking at those labs that would either identify the hepatitis B reactivation or those clinical outcomes, I think in that period of 1 to 3 months early on. And then among those who are on prophylaxis and steady and stable, I'll monitor them much less frequently, again, 3 to 6 months early on, and then really go out to every 6 months if they're clinically well.
Got it. And it looks like we have a question that came in the chat. With Hep B reactivation, does hepatitis delta risk routinely included in workup, or is that of no concern usually?
Yeah, it's not factored into the current recommendations about how to risk stratify, but certainly increases the concern about fulminant liver disease outcomes. And so on a individual basis, if would being including that in our discussion, as would HIV screening as well, to inform your decisions about use of hepatitis B prophylactic therapy.
And then for somebody who may, doesn't go through prophylaxis, and then you see elevated DNA emerge or a surface antigen come about, what do you do in that scenario, maybe?
Yeah, no, that's great. Usually, so that would fall into that preemptive therapeutic strategy where you'd want to start them on therapy once you identify, and preferably early on, in order to reduce the risk of those more significant clinical outcomes of liver failure and death. And the earlier, the better. We know that in patients who develop hepatic synthetic dysfunction, icterus, liver failure, that even when starting Hep B active agents at that point, patients still may not be able to be rescued from that disease process. And so earlier rather than later, once reactivation is identified, is important to start those Hep B active therapies.
Got it. That's really helpful. Thank you so much. And then another question that came through, you may have stated this earlier, but what % of patients on immunosuppressants are being screened for hepatitis B, and what's being done to improve these pre-screenings?
Yeah, that's a great question, and it varies widely. If you look at surveys of providers, you'll see a range of people saying, I screen my patients anywhere between 10 to 70%, and it really depends on specialty. One of the examples I presented was among people starting B-cell depleting agents, so that would really be in the realm of oncology and rheumatology, and really in 2014, just about 50% of people were screened prior to treatment. So still have a lot of work to do. I think, more recently, that is in the last 5 to 7 years, the society guidelines for both liver disease and oncology, rheumatology are really starting to align with recommending screening for everybody who's going to initiate immunosuppressive therapy. So I think that will hopefully help, because as you may be alluding to, if we use just risk-based screening strategies, we really miss a significant portion of people who ultimately have core antibody antibody positivity or surface antigen positivity. And I think more globally, recommending universal triple test screening for everybody at least once would really decrease the chance of having these Hep B reactivations go unnoticed due to insufficient screening. So I think that would be a great strategy.
Yeah, definitely agree. That's really helpful. Thank you. Any other questions? Awesome. That's really helpful. Let's see. One thing that came up outside of reactivation, but related to core recently, with core antibody being positive, when you run a panel, you may do surface antibody testing and the antibody is low. Is there any significance to that antibody being low? I know I've heard of providers trying to vaccinate. Is that the appropriate strategy? I know this is probably a little bit off topic, but just an important point potentially.
Yeah, I have not seen any data that suggesting that in those with isolated core antibody or with low level surface antibody titers that changes their clinical outcomes, either with reactivation or prevention of downstream impact from hepatitis B. I think there was a recent publication that suggested vaccinating people may decrease the risk of HCC from Hep B down the road, but that has not borne out with actual clinical findings to date, to my knowledge. Among those in the oncology world, there are some data suggesting that if you have a Hep B surface antibody titer greater than 100, which is essentially that protective strategy that you would want, they have a lower risk of Hep B reactivation in the setting of therapy. But again, that's not sufficient to prevent Hep B reactivation across the board. When you look at your lab titers, anything greater than 10 international units is considered reactive. And so that 10 to 99 range, what their absolute risk of reactivation is unclear, but certainly an area where additional data would be valuable to inform any other interventions to reduce that reactivation. Did we lose Catherine?
Looks like she froze. I'm gonna contact her now.
Okay.